Okay, so yeah, the title is quite long, but the slides are not that long, so hopefully I can cover in more time. So what I've done here is I'm going to present some of the work that I've done during my PhD, but also talking about a little bit about the progress I've done during my postdoc. So what I'd like to introduce you first is two different types of simulations or computer models that I came across. I've separated it into two parts. So one is what we call finite element model. The other one is what we call musculoskeletal models. There are quite large varieties of modeling and simulations out there to answer healthcare problems or model biological systems. In this case, I was focused into two. So during my PhD, I focused into finite element modeling. And in my postdoc, I'm now focused in using musculoskeletal models. So finite element model, as the name suggests, is an element made into smaller parts. As you can see here, this is like a body with smaller parts. That's what we call finite. And it can be used to predict soft tissue biomechanics, in particular, such as the skin, the cruciate ligaments, tendons, muscles, those sorts of things. So we're looking at the structure of a soft tissue, or sometimes harder tissue, such as the bone in the knee joint, or not so soft, such as the meniscus between the knee joints. So there are some large variety of modeling out there for finite element models. This musculoskeletal model, as the name says, is a muscles attached to a skeleton. And it's mainly focusing on the how does the muscle affect the joint movement, the body movement, how does the body movement affect certain muscle, and how much activation you get for within the muscles as well. Some people looked at the overall body of musculoskeletal. Some people just look at as you would want. So in my postdoc, I focus on the upper limb, just a heads up. So in order for me to explain a little bit about finite element models, I'd like to describe it through an example. So this is an example one of my former collaborator at Manchester University worked on. And what she was trying to study is how does a suture, the tendon suture, affect the soft tissue, and what can we change within the suture in order to make it easier and not create lots of rupture or stress around wherever the suture is. So to do that, what she's done is she created a geometry, first of all, of the tendon. So this is a very approximate geometry of a tendon. And also she modeled the suture itself. And then after creating a geometry, in order for you to create the model, you'll have to change the whole geometry into finite elements. And each of these tiny, smaller elements has an equation assigned to it. So by solving each of these individual equations, you will create a whole simulation of the part you want. And then you can look at the results of that. So for example, in this case, there's a stress distribution across the tendon, and the suture seems to have created a lot of stress around this area, and then coming out, and then not so much when it comes out, but since wherever it is tangling around, it's creating quite a lot of stress. And this is very important because then we can look at how can we modify the suture and create different surface on the suture, or using different materials, having more elasticity, or make it more robust, or any sort of material property that we can characterize later on. So these are really good tool to predict what you will get from the surgery and what will be the impact of that suture within the body. So what I have done, apologies if you're very, look away if you're very squeamish. Basically, what I've done in my PhD, I looked at knee joint, but because it's very difficult to look at the knee joint or getting a sample from a human cadaver, I used dog as a sample. The reason is because dog is thought to be very comparative to human. So I collected knee joints from dogs, and I dissected the ACL of the knee, because I was very interested in how does one type of protein that's called proteoglycans affect the soft tissue. Does it make, if you take it out, does it make the ACL stronger? Does it make it stiffer? What does it do? What would be the impact of that protein to the microstructure of that tissue? I'm not going to go into detail of exactly how I digested the proteoglycans. It's a very tedious way to do it. And it's not guaranteed either. So you might end up getting 20% out of the tissue because of how the structure of the tissue is. But in brief, what I've done is, so the focus here, I looked at the ACL, and then I created the fine element of the whole joint, including the ACL and the other soft tissues within the knee joint. So after collecting the ACL, I carried out a mechanical test on them, and then created a FEM or fine element model of the joint, then carried out analysis to tell me how did this protein affect the overall behavior of the joint. So this is how a dissected ACL looks like. Again, it's tiny because you're looking at dog. Human ACL are a lot longer. And there's a mechanical test, which is in a chamber, that just to make sure that the sample is actually not dehydrating, because that, again, any sort of change within the environment affects how the sample behaves. This is what we have to remember. This is outside the living body. Therefore, whatever we do, it would be an approximation. So we have to minimize all of these uncertainties that comes with testing a sample outside the body. So this is a closer look of the ACL and the T-clamps. I've designed all these setup, designed the chamber that can adapt within the setup. And then from the tensile testing machine, so what you do, you just clamp it from the bottom and you pull it up. You'll get a sensor, the crosshead, then when it moves, the reaction from the sensor that moves up will give you how much has been extended versus how much by how much when you apply that certain load. And this is basically defining how my tissue is behaving. So, and then I can compare the normal behavior of ACL versus an ACL with digested protein or proteoglycans. And the next was, then I had to create my FEM of the knee joint. To do that, I took CT scan of the knee joint. Again, this is a knee joint of a dog. That's why it might look a bit odd. So it's not, it's not very much representative of how human knee looks like. But they were also cadaver. So they were stored in a freezer for a while, and I have to defrost them, and then I have to scan them. So there was some deformity has happened within the soft tissue. So if you're looking at this and you're very familiar with how animal samples look like, that might be why some of the tissues might have been deformed. So creating the FEM from the CT scans, actually from the MRI scans, not CT scans, was a very manual process. Was very much taking time because it was a manual process, and I had to segment each part of each slices of the MRI image to create different parts of the knee. So, for example, I've created the green area here. This is a 2D image, and then when you stack up all of these 2D together, it will give you a 3D shape, which is what you have here. And then I added all of these soft tissues around it. So you have ACL, PCL, and then the collaterals, one in the two sides. So these are the four major ligaments in the knee joint. That's also, those are the very important ligaments to provide stability for the joint. And once I've created this, then I had to change this. This is basically useless for engineers because that's just a model, beautiful, but it doesn't do anything. So I had to change that into a finite model using a software, and then look at, apply certain loading into the joint, and look at what will be the impact of it. So this is a picture of my supervisor. She was trying to test what we call an anterior transition. So when you basically hold the top of the bone and you try to move that forward and see how does it move. So that is what we call a transition off along the side. So I applied that exact loading into my model, and I looked at how much the stress is distributed, which ligament is causing a lot of problem, and predict the outcome of it. So I made a comparison between a healthy one, a healthy knee without digesting the proteoglycan, and also looking at one with digested proteoglycan. So what I found is when you digest proteoglycan, it seems like the tissue loses quite a lot of water. So it seems like it dehydrates. So when the tissue dehydrates, it gets stiffer. Therefore, the overall behavior of the joint changes as well. Although it was only 20% of the proteoglycan was digested through the methodology I was using. So further work hopefully be using different methodology to digest a lot more proteoglycans. So, and this is a video showing, it's not going to snap, it's just a simple loading, pulling the bone from each other. And you can see this is the two ligaments, which is crossing, that's what I call cruciate ligaments. And you can see the stress distribution across the surface of the ligaments. And you have the two sides as well. So this is missing the meniscus in both top and a cartilage part on the bone surface as well. Okay, so that was FE, finite element analysis, and what I'm doing is musculoskeletal modeling. So I use musculoskeletal modeling for my postdoc. It's very new. I'm still learning along the way because I've not used this before, but the concept seems to be very similar. All the modeling seems to be wrong, so there's no model that's correct. So we have to be really careful of what we tell people. Okay, this model predicts this, but remember, model is wrong. So, to define my model, I have to first, a musculoskeletal model, I have to first define the muscle behavior, and then define, which is however mathematical equation you use to define it, and then I need to define the geometry of my bones, and then look at how am I putting all these components together. So the muscle model is based on a very well-established Hill's muscle model, which comprises of three components, representing different parts of the muscle. For example, the contractual element is representing the cross-bridge that has been created via axin and myosin, and tendon has been represented by this part here, which is a nonlinear spring model. And you have another nonlinear spring model that is taking into account how the surrounding tissue within the muscle affects the overall behavior. So that whole thing tells me how a muscle should behave, and this is based on experimental research. And the next one is create the geometry. So I need to know how does a geometry of somebody looks like. So I need to know what is this part, the humerus of a person, how long is it, where is the bony parts, where does the muscle attach, and also is there any muscle that's wrapping around it that creates a more complicated model. So all of this information I have to collect in order for me to create a musculoskeletal model. And then finally, I have to define where is the center of mass of each part, what is the maximum angle that I can create in joints. For example, in here, this is representing a head. I'm not sure what that is. Seems like a beak. So this is a joint, a shoulder joint, elbow, and a wrist. And this is this part, the front forearm, and that is the humerus, representation of humerus. So defining all these parameters will then create the whole musculoskeletal model. So, what is my current project, and how am I going to use the musculoskeletal model that I've just described in my current project? And so, overall, this is defining the whole project, but I'm not involved in all of it. Some part of it are being delivered by my co-PI, who's currently in Aberdeen. But I am involved in creating the musculoskeletal model and making a personalized model for each individual patient, and then use this information to optimize the use of an existing device. So to summarize it, my current project is basically looking at how to use an existing device, but optimize the use of that in patients who have spinal cord injuries and they can't move their arms. So use this device that's already existed, but use it better so that people can make use of that device to move their hands and be more independent. And then my contribution comes in here, where I will personalize this model, make sure that it matches individual people. If a patient has a longer arm, would not have the same optimization process as somebody with a shorter arm. And the optimization is important because then it will tell us what muscle do you need to stimulate, by how much and at what time, in order for you to create certain gestures of your hand. And that is where the computer simulation comes into it. So this is the process. I have a generic computer model. So the line represents the muscles of the upper limb. And again, we have to do quite a lot of simplification to make that model not be too computationally expensive. And then I have this generic model. I have to personalize it to each individual patient. To do that, I collect a lot of manual muscle data. So, for example, if somebody has very strong grip, I will take that into account, and I will have some sort of control constraint within the model to define that strength of that individual. And then how do they respond to electrical stimulation, which is the device I'm optimizing its use. So once I've collected that, I'll input this into my generic model, and that is, right, we have a personalized computer model. And then I can use that computer model to tell me where can I stimulate, or which muscle to stimulate to create what gesture. And here's the fun part. This is some videos of the muscle I've so far created. So in here is just a rotation of the personalized muscle. It doesn't have a skull because you're not interested. And we have muscle around the shoulder. And this one here, what it shows is when you move your arm up and down, some of your muscles get activated and some of the muscles are not active. So that's what basically shows. So the blue, the purple, it means it's activating, it's pulling, contracting to create that sort of gesture. And then the pink dots here, they basically represent markers that we put on people by when you're tracking their movement, and those markers are tracked alongside of it. That's where we get all these movements from. So going forward, what I would like to achieve is take this model further and use the information we get from electrical stimulators and look at how can we use this information into the model, and how can the model tell us what muscle to stimulate to create certain angles. And that's very much where I am at, and I'm looking forward to recruiting more patients to carry out this project. And it's a very interesting project because I work quite a lot with clinicians, and I'm an engineer. I haven't had that experience before, and I feel very lucky to have this opportunity. Right, I'll leave that here so you can keep looking at it, waving at you, but I'm open for questions.